Okay, without further delay, it is my pleasure to announce and introduce our keynote presenter this year, Dr. Ali Khan. Dr. Khan is the distinguished public health leader and expert in infectious diseases, currently serving as the Dean and Tenured Professor of Epidemiology at the University of Nebraska Medical Center. With over 3 decades of experience, Dr. Khan has spent his career advancing global health security and public health preparedness. He has managed numerous public health emergencies, including Ebola, SARS, and hantavirus outbreaks. At the CDC, he led the Office of Public Health Preparedness and Response, enhancing U.S. readiness for health threats. And internationally, he has worked with WHO's Global Outbreak Alert and Response Network to control infectious disease outbreaks globally. Please join me in welcoming Dr. Ali Khan.
Good afternoon, everyone. Can you hear me back there? Excellent. I want to thank Dean Ackerman for his leadership. Wonderful session this morning, and I really enjoyed the various poster sessions. So I only have 35 minutes. You'll learn very quickly I'm a New Yorker. I think I have about 60 slides or something like that. So we need to get to it right away. I had structured this really about the opportunity for what's possible in medicine and public health. But let's just admit the elephant in the room. Yesterday was a bloodbath, okay? If any of you read the papers yesterday, hard to miss, right? For somebody who spent 23 years at CDC to essentially see CDC, FDA, and NIH essentially decimated, whole offices, whole cloth just disappearing around patient safety, surveys, occupational health and safety. I mean, I could just go on and on. But gun violence and prevention. I'm actually thinking about the posters I saw, and I'm like, we're not doing that anymore. No, we're not doing that anymore. Climate change, no, we're not doing that anymore. That said, I'm still going to keep with a positive theme because I believe that this environment, even in this environment, we can succeed. And I say that as somebody who comes from an extremely conservative state. And we have deans in public health programs across America that do very well regardless of ideology. And I want you all to remember that. While we may have our own philosophies and beliefs, public health is nonpartisan and always must remain partisan. So I'll make sure your dean doesn't get fired today, okay, at the end of my talk, because at the end of the day, we're about the health of each and every person within our community, and we need to remember that. All right, so I thought what I would do is let's just talk about us and where did we come from, okay? Before I start, I always start with thank yous. So thank you to Dr. Bob Ronner, you'll become very clear. All of our work we're doing in our state about aligning public health and healthcare at an individual level to scale up to a community level. Bob runs those efforts. He's actually started 2 accountable care organizations in Nebraska during his time. Dr. Ali Muqtad, old friend at CDC, who's now at the Institute of Health Metrics and Evaluation in University of Washington. A bunch of his slides, if those of you follow the global disease burden work, they do that work, and they've now moved from, actually not just globally, but in the United States also, in a great set of papers that came out this winter. And Alex Todd was one of my students and now is responsible for putting together these great set of slides. So let's start at the beginning. There's lots of beginnings. For me, the beginning starts in the interglacial. It's about 12,000 years ago when we went from hunter-gatherers to essentially farmers. And that's when we started with magic and shamans and witch doctors. And medicine, believe it or not, has our origins right at the beginning of when we think of modern history, or at least what I think of modern history. And then I love to show that even in the ancient world, so physicians, this isn't a new concept, right? Even in the ancient world, right, we had physicians, we had medical texts that were being published at that time. People understood the value of personal hygiene a very, very long time ago. medieval times, so quarantine and isolation may seem like newfangled ideas. They're not newfangled ideas. They're very old ideas, right? Even before anybody knew what germ theory was, they understood that you can somehow get infected by something in the environment. In those days, mainly we said miasmas, but you could get infected from the environment. So old concepts, right, just based on observation and observational skills. And so this sort of, hoping I'm leading you into what soon will be really good science that comes out that sort of forms the foundation of our professions. Right, so I'm going to give you the Renaissance here, infection, disinfection. Now science starts developing, anatomy, physiology, chemistry, a little bit more sense of observation, what's going on in our world. Moving on to the Enlightenment. Thank you, microscope, and thank you for my career, microbiology, microscope. Very good. I wouldn't have a career if it wasn't for that darn microscope that showed up. And then epidemiology slowly begins to develop, actually, how can I not forget, during the time of Enlightenment, vaccines are not new, okay, people? A very old concept. And you know what's also a very old concept? Vaccine hesitancy is a very old concept, right? Even with the original Jenner vaccine, people were like, oh my gosh, cows are going to start. This is an original cartoon, right? People have from cowpox, and they're like, oh, these cows are sprouting out from us, and we're going to become cows, right? Does that sound very familiar to mRNA vaccine, that somehow is going to change our genetics and make us into something else? So it's not new. These are old concepts, and we need to remember how we addressed those concepts on how to think about how we go in the future, okay? None of this is new. And it always helps me to think about the world when I remember where we were and where we've come from on how we tackle the future. Industrial age, not such a great age, right? Great age. Let's just admit that, right? Pollution, environmental degradation, left and right child labor, so not such a great age. However, at the end of the industrial age, much better age, right? So we've got modern hospitals now, we've got modern statistics now, and we've now actually got evidence-based medicine, okay? So really great time as we sort of lead out of the industrial age into what I would call now the modern age. So let's talk about the modern age, or public health now. And public health now is about measles and cod liver. No, I'm sorry, this was the industrial age. Oops, sorry, bad on me, I put this slide in the wrong place. Okay, let's really go to no, we don't talk about cod liver oil and measles anymore because we figured out how to deal with these issues of rheumatism and tuberculosis with drugs. Okay, so the modern era. The modern era. Here's your modern era. A spoonful of microplastics in everybody's brain in this room. And I'm thinking, how much more before I get the full set, right? I want the knife and the fork too, right? Why do I just get the spoon in my head? So more microplastics in my future. Obesity, definitely. Bird flu. Lots of fake news, which has all sorts of meanings depending on what side of the fake news you are. Climate change and a whole bunch of measles these days. So this is I would say is a quick snapshot of today, and let me give you a little bit more details of where I see public health today. And yes, I'm all for what the future holds for us. And the reason I gave you that little quick slideshow of the past is I think you always need to have clarity on where you were and where you are before you decide I'm going to go tackle the future. And I think that clarity is really important. Not just some general sense of things were horrible once upon a time and I'm going to make it super future great in the future, right? So that clarity is important if you really want to think about what your interventions need to look like. And all of that, I would say, based on good science. As I chatted with some of the students, I wanted to remind you who still want to become clinicians, public health practitioners, that public health and medical practice is based on excellent science. And so we need you, and please stay the course. So the United States, I think this should not be new to you, right? We spend twice as much as any other country in the world on our health care, and it pretty much takes up about 20% of every dollar spent in the United States currently is spent on healthcare, which is just a god-awful amount of money. Now, for that god-awful amount of money, what we don't get is a god-awful amount of public health within our community. So if you look at comparable countries, again and again, and this is consistent, this is the most recent data I have from the Commonwealth Fund, we rank last pretty much in healthcare indicators. And it's interesting if you step back to say that this really was a transition that happened about 40 years ago. So sort of in the 1980s. We were doing relatively well to our peers until about 1980, and then we sort of started falling off since then. And today we're about, what does it say, four years shorter than comparable countries. So fall off over the last 40 years, and we'll talk about why in the next set of slides. But again, that clarity of where we are in the United States. And this was some really good work by Jacob Bohr coming out of, Jacob's out of Boston, I think came out 2 years ago, who basically said that in the United States, if we were just average to the other comparable countries, we would save 1 million lives a year. Now, you're going to die eventually. Let's just admit that. So we're talking about preventable deaths, right? So 1 million fewer preventable deaths a year. And this is not, people 65 and older. Half of these deaths are people less than 50 years of age, right? And it's about drug abuse. It's about It's about alcoholism. It's about suicides, gun violence. You know the routine, right? So half of these are in people 50 years of age and older. So I could probably stop my talk right now because this is your opportunity, right? This is your opportunity to take the great science, the great tools, and the great practice that we already know works to save these 1 million people every year so they have longer, healthier lives. But since I have 30 minutes and then 60 slides, we're going to keep on going. And so this is a really nice analysis in The Lancet, and I would actually suggest these series of papers to everybody in this audience and actually to every public health practitioner, period, that sort of looks at the root causes. So, we're used to talking about diabetes and heart disease, et cetera, but this sort of looks at the root causes of why do we have all of these preventable deaths, and why do we have this increase in disability-adjusted life years in America? And there's no doubt, if you go to the top of the list, it's all about a high body mass index, right? All really comes down to obesity and diet in America. And of course, tobacco's better be up there, right? Tobacco's going to be up there. But that is the main reason we see for these chronic diseases being at all-time highs in the United States. And this shows you what's happened since, I guess it's about 20 years worth of data here, of what we've been seeing with increases in obesity in America, which may or may not have peaked yet. It's 1 year worth of data. Some people say that this sort of slight decline we're seeing is due to the GLP-1 agonist. Maybe, maybe not. I want to see a couple more years of trend to see if it is going down. But regardless if it's going down or not, 40% is not a good number, right, for people in America who are obese. And that doesn't include the ones who are overweight. And it's all age groups. The other thing that I don't ever want to step past is the great disparities that are in America around healthcare. And I think probably 1 out of the 2 posters I saw today were about disparities. And congratulations, Kathy, for your award, which also was about disparities, right, earlier today. So the IPHAM originally did a version of 8 Americas. They now have done a version that's essentially about 10 Americas to make the point that health in America is not homogeneous. And no matter how you want to do it, you cannot deny the great disparities that exist in America about health and the opportunity, the equal opportunity to be healthy for each and every person. And what you see, I can show multiple slides in various ways, but this is just a nice, clean way to just look at life expectancy at birth. So basically, for those of you who've been in DRs, had babies, seen babies, you just look at this baby and you go, guess what? I'm going to guess how long you have to live. Right? That's horrific, right? That's just horrific to me, to think that we have just defined at that second that this child's going to have 10 less years of life to live. right, based on where they were born, how they were born, who they were born to, in a country with our amazing resources that are available to us. So this is undeniable, right? Health disparities exist in America, and we need to address them to ensure that everybody has an equal opportunity for health. So let's give you a little snapshot of your state. So it looks like for the last 30-odd years, you've been ranked about 25, I guess, what's that, 27, 25 to 30 on average for the last 30-odd years. And there's lots of opportunities. You have a lot of strengths in terms of your low prevalence. You can read faster than I can say, right? Low prevalence of frequent mental distress, drug use, et cetera, adverse child experiences, and lots of opportunities around homicide rates, excessive drinking, and black-white residential segregation, right? So there's lots of opportunities here within your own state to be healthier. I show you your own data to make the point, disparities, right? You just can't get away from those disparities. And I can put these health outcomes, this is from Community Health Rank. The last slide was from United Healthcare's America Health Rankings. This is the more nuanced data coming out of Wisconsin on the county health rankings and roadmaps. And then I could overlay this sort of health outcomes over various measures of community indexes to let you see sort of why we see these disparities within our communities. So disparities exist. Oh, and you are not immune from the obesity trend in America. So as I said, I spent 25 years in Atlanta, and I thought, oh, obesity is a Southern disease. That's what I always thought, and there's no doubt. If you look at the 10 most obese cities in America, they are in the South. However, obesity is not a Southern thing. Obesity is an American thing, and you can't escape it no matter where you happen to be in America, including right here. So let's talk about the fun part, right? Let's talk about where do we go from here? Where's the opportunity for everybody sitting in this audience, everybody engaged in public health and healthcare related issues? I am not sure what to call this game, but I just loved this slide on how do we go from here to getting healthy, because it is a complete mishmash. And something, again, where I think, public health and healthcare working together can navigate this sort of mess. Let me show you how we do it in our state first. So in Nebraska, having the advantage of being at the College of Public Health, we were able to convene all the health systems in the state, our large academic health center is Creighton. We were able to convene the state and local health department, all of the insurers, all of the health system and key partners to come together and say, what can we do at an individual level that would scale up to community-wide health? Right? And we all came together with these 12 measures, and these are the measures now that are essentially coming out from the Milbank and a lot of other institutes to say this is sort of what you can work on every day that will really have a community-level impact, a state-level impact. And we've been tackling some of these one by one, but the advantage of tackling them together collectively in the whole community is that we've been able to see significant changes. This is an eye chart. This breaks every rule of slides. So all I want you to pay attention to is green, okay? And so these are the accountable care organizations in our state, which we work with a lot, right? So across the top is all the various accountable care organizations and their measures. So, but these are usually Medicare organizations, right? Now, accountable care organizations usually have better health outcomes than any other health organization. And these green shows you how the Nebraska accountable care organizations do in respect to other accountable care organizations. So the more green you are, the better you are than other accountable care organizations. So right now, for our Medicare patients in Nebraska, you pretty much can get the best care in America right now. And a lot of this was a function, so these are the dark greens you see everywhere about these, whether you look at those measures, influenza immunization, colorectal cancer screening, breast cancer screening, depression screening, hemoglobin A1C, hypertension, blah, 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 blah. You have the whole, if anybody wants my slides, you can share them. But the point be that you can make this happen if you're willing to work together within the community, with the community to say, this is what we would like to do. So if you all row together, you can really have a major impact. Now, this is, as I said, Medicare patients. This is our Medicaid population, again, subject to the same amount of work. And again, you can see, yes, we have some work to do, but the nice little green stars are to make the point that when you start focusing on something together, you can make a difference. And in our red state, we got our governor to agree, and again, we're one of the last states in the union, unfortunately, to go 60 days of postpartum care to a year of postpartum care, right? So it's embarrassing that we're amongst the last ones, but we got there because, again, people care about children, right? And so we could make the argument for these policy changes. And now we've actually expanded Medicaid, believe it or not, so that any pregnant woman gets an extra package of services starting this year. So again, good work. There's good work to be done in this environment, however you want to frame this environment. And here's something else that's been a focus of mine specifically, which is around cervical cancer. And, places like Scotland are like, cervical cancer. What's cervical cancer? We don't know what cervical cancer is anymore. It's because they vaccinate everybody, right? And so what a great opportunity here to get rid of a preventable disease, get cervical cancer down to zero. And for those of you who are head and neck surgeons in the audience, I'd love to put you out of business too, right? Yes, get rid of the smoking, get rid of the cervical cancer. You could do lots of other wonderful things with your skills. Right, so I guess I tell people my job is the anti-doctor job, right? It's like get people out of the medicine business because we have health or the best healthy choice is the standard choice. What am I showing you here? Oh, another big example, infant mortality. This shows you your infant mortality. I could have shown you anybody's. The point is, you want to be the national Healthy People 2030 goal is 5, which is still 2.5 times higher than what you can get in Europe. So it's kind of embarrassing that 5 is what we're aiming for. But that said, we're aiming for 5. You're not at 5. We're not at 5 either. But there's a piece of this that people don't recognize, which is the cost of this increased infant mortality, right? And so a lot of this is about babies that are born early. So it's not more mortality, it's also about morbidity. So babies born early go to NICUs. Do you know what's really expensive in America? NICU care is really expensive in America. And if you could take 10% off of NICU care, hello, that's like billions of dollars that would be available to do other fun stuff. If you could just 10, I'm not asking for much, just 10% off of NICU care. And there's the piece of, and so I got the NICU care. I'm not the smartest tool, sharpest tool in the shed, but I got the NICU care. But Bob Runner, who sits on the school board, said, Ali, do you know what our biggest cost is in our school system? Anybody ready? Where was my slide? One of their biggest costs. Come on, Ali. Now you've seen everything I'm going to show you. You're done. I can leave now. Thank you. All right, let's get us back to one of the biggest costs for school systems. Yes, please, right there. School systems, one more. Nope. Yes. There you go, special ed expenditures, gigantic expense for our school systems, right? What does that say? $38 billion in America spent. And so, do you know what happens to some NICU babies? They eventually need special education services in schools. Do you know what it would look like if you could just take I'm not being greedy, just take 10% off of that, right? What would that be? I can do the math, $3.8 billion, right? That's a lot of money. And I don't think we as public health professionals make that, and clinicians, we don't make that argument enough. For me, saving lives is enough. For some people, they want you to do a little bit more. Okay, well, we'll save you money too, right? We'll make this a healthy community. I don't think we ever make this argument as well as we should about what the advantages could be if we do this public health work collectively every day. This shows you, if you look at the American Preventive Services, where's the most gain to be had if we can sort of get people healthier. Without a doubt, hypertension is a big chunk of that. Heart disease is the leading cause of death in America, right? Hypertension, hyperlipidemia, treatment is a big chunk of what you can do there. Probably half of Americans have hypertension, myself included. Probably less than half of those are actually treated, and even a smaller percentage are actually adequately treated, right? So lots of opportunity there in the healthcare system alone, without forget about public health, just in the healthcare system to make sure you identify these people and treat these people appropriately. So there's an opportunity there. This is another lovely slide that could show you that if you sort of did colorectal screening, and I didn't think they asked for very much. Yes, 66th percentile. So just don't be very good, just be kind of good, right? So if you're just kind of good, you can save a whole lot of lives, and as you do with colorectal cancer screening, and if you do with hypertension control. And I believe right now we are on the cusp of a generational opportunity to improve health in America. If we think about the tools that are available to us, if we think about hypertension control, if we think about hyperlipidemia, if we think about diabetes now with the GLP-1 agonists that are available to us, we are at a generational opportunity in America to help Americans live longer, healthier lives. And so that is what I want people to see and hear from me today as where that opportunity is. And that's where public health and healthcare working together. This is what we can do if given the opportunity to do so. And we should be shouting this from the rooftops, because guess what? Besides saving lives, I know saving lives, what else does this do? Saves money. Saves lots of monies, right? And if you look at state budgets, what is usually after education, what is number 2 often for where the money goes? Health. Somebody said it already. Healthcare, Medicaid, right? Right. So this is where it's one. I know a lot of us are physicians, and I hope I'm not attacking you as physicians, right? Because people are like, all you want to do is like put us out of business. But come on, there's lots of things we can do besides what we do now, and we'll still be in business for a while. Trust me. So let me end here. All right. So I want to end with 3 messages to you, but those messages start here about what we need to do as academic institutions. And I think you at Northwestern, us at Nebraska and elsewhere, I think we have a greater responsibility than others within our communities to step up, right? Step up, say the right thing, do the right thing for our communities, and with a values-first approach, right? There's a whole lot of people who are looking for beacons in the current challenging environment of people who are willing to talk about their values and what's important to us as Americans. And I think that's a key role for academic institutions. And that may be my bias, but that will always be my bias. So 3 things I want to leave you with. Number 1, this public-private partner, public-private partnerships are good too, but this medicine public health partnership, which is the reason that got me to my current institution. So when I gave you that history lesson, right, public health and healthcare were always together. Get to the mid-19th century and epidemiology and statistics and John Farr. And so public health science became more robust. And so public health and healthcare started to do this, right? And then you get to 1915, you get the Welch-Roche report, which is the equivalent for the clinicians in the room with the Flexner report. So you get the Welch-Roche report sponsored by the Harvard Rockefeller that said, you know what, maybe we should have these colleges, schools of public health as separate disciplines or entities. And so public health and healthcare continue to do this. I will tell you, I think that was a mistake. Right? And I am actually jealous of your model here with your dean of healthcare and public health in the same institution. And if there's some way I could force that back again at multiple institutions across America, I would force that back again to say that we are one, we have always been one, and we should be one, because we have the exact same mission every day, which is to make our individuals healthier and to make our community healthier. And I think everybody, hopefully, in this room would agree with, no matter where you are in that spectrum between healthcare and public health in your community work. I think it's a single mission-driven activity. And so we are big fans of dual MPH certificates and degrees for all of our healthcare providers, not just Oh, good. I'm glad I didn't just say MD there. I think that's true for nurses. I think that's true for PTs, OTs, you name it. I don't think we should be graduating any practitioner. And my expectation is at a university with your reputation, you're going to graduate excellent practitioners. But I think at the same time, they may not necessarily know what the practice environment that they're going to go into and have those leadership and other skills that they need as practitioners within their community. So we're big fans of those joint programs, which obviously you have here, but those of you who've not yet signed up for your MPH or certificate, the dean's right here in the front row. I'm sure he can help sign you up. And this recognizes the fact that you as clinicians, and you know this, you have a role outside of the bedside, right? If you want your patients to be healthier, you need to be thinking about those root causes of illness, right? And how do you address them? And you do address them. So today's morning's conversation was so eloquent that way about Maslow's hierarchy of needs, right? Somebody walks into the room, right? You need to meet their immediate needs. Well, guess what? Those are often those root causes of why they're there. It's not their diabetes or their hypertension, unfortunately. And that's where that public health and medicine piece comes together. And kudos to you. I think Dr. Moskowitz is chatting about resilience and resilience for clinicians, practitioners, and resilience for your community. Just to say that this work is not unrecognized by others across the community is that part of making sure that you yourself stay resilient. And I want to be careful, this goes back to an earlier comment, not to make you, I don't want resilience to become making you a better victim, because Dr. Cook, was it you who talked about systems early this morning? Better systems, not just better individuals, right? So I don't want you to make you better victims. I want better system-related work, but it is important to be more resilient. So that was one. The second piece I want you to remember, and this is a hard piece, is about the collective, right? So if you think about America and the story we tell about ourselves, we talk about this individualism, this exceptionalism, right? That's how we often tell our stories about America. That's my story, right? My dad came to America with 20 bucks in his pocket, 20 years old, from a mud hut in Kashmir, and that's where he got his start, 5th grade education, right? And thankfully, that led eventually to me and my children, right? That is the story we tell about the individualism. But there's another story to be told about America. That's about that collectivism, right? Of us coming together as a community to support each other, right? The great grand projects that led to Social Security in America, Medicare, Medicaid, right? There's another story to tell, and we need to be telling that story also. Otherwise, the story you get is medical freedom, instead of, you know, we vaccinate each other as a social construct so we can make everybody healthy, and so that Johnny, who has organ transplant, a liver transplant, when he goes to school, he's not worried about measles, right? Because other people have decided to protect Johnny, who can't, unfortunately, protect himself, right? So we need to tell that collective argument also of why that collectivism is important. And that's the work we have to do, right? And this is a reminder of public health is everybody. And then the third thing we need to do is this. And we need to remember that health equity is not a dirty word, right? Diversity is not a dirty word. We may have to think about our language depending on the audience we're approaching, but this is about health for everybody within our communities, right? And that's what leads to great, healthy communities, right? Robust, vibrant communities when everybody has an equal opportunity. So for me, at least, I will always say health equity is not a dirty business, and I actually tell people when they show up at school, when I do my introduction to the college, I go, you're here because you're in the social justice business, right? And if you're not in the social justice business, you're probably in the wrong building right now, right? That's what I believe we are. I believe we're in the social justice business, right? And I want to end with, let's not break what works, right? So for all my little dings at clinicians, I want to remind ourselves we have exceptional, if you can get it, we have exceptional health care in America, absolutely exceptional, right? I have circled the globe multiple times, spend most of my time actually is spent abroad in most of my work. If I want healthcare, do you know where I'm coming? I'm coming right here back to America, right? Our healthcare is exceptional. Here's the same data, same group to sort of make that point, right? We just need to make sure that that's available to more people, obviously, within our communities. But let's not break what works really well, which is the exceptional healthcare in this nation that's underpinned by an amazing biomedical research infrastructure, right? So that we have great practice as we are out there. I think I have spoken as fast as I can, so roll up your sleeves, people, for the American people. Thank you, everybody.